senior and junior residents to today's afternoon program of clinical case discussion of interesting cases. So today we have total of 4 cases in total. The first case, rare case of recurrent brain cyst and its management from Department of Neurosurgery, multiple splenic abscess from Department of General Medicine. The case of silent pressure surge from Department of Pediatrics, atypical filariasis from General Medicine. So therefore we will start with the first case, rare case of recurrent brain cyst and its management from Department of Neurosurgery, presented by Dr. Amulya Bhagya, moderator Dr. Srinivas.
Good afternoon, one and all. I am Amulya, second year general surgery resident, presenting interesting case of neurosurgery. A 71-year-old female patient with no significant medical comorbidities presented with chief complaint of headache since 2 months, vomiting since 1 week, and altered sensorium since 1 day before the time of presentation. History of present illness. Patient was apparently asymptomatic 2 months back. Later, patient had headache on and off with intermittent increase in intensity associated with vomiting, which is projectile non-bilious since 2 days. History of 1 episode of loss of consciousness followed by state of unresponsiveness and involuntary micturition 2 days back. No history of trauma, fever, weakness of bilateral upper and lower limbs. Personal history. Mixed diet, regular bowel and bladder habits, disturbed sleep and appetite normal. Surgical history. Patient had history of brain surgery. Left temporoparietal craniotomy with marsupialization of arachnoid cyst in 2017. Recurrent left parietal arachnoid cyst with marsupialization with Gomayo reservoir placement in 2021. General examination. Patient is drowsy, arousable, confused and following verbal commands. GCS. Vitals are within normal limits. Systemic examination unremarkable. Cranial nerve examination. Cranial nerve 1 intact. Cranial nerve 2 intact. Fundus examination not done. Other cranial nerves are examined and found to be normal. Diagnosis. Recurrent left parietal arachnoid cyst with raised ICP.
Some amount of platina. The previous slide. Previous. Yet. Not done in a present ఉండకూడదు in institute. It should be done, that's all.
No, it interferes. Fundus examination in an emergency case interferes with management. So, what happens is...
Sir, I asked the question for the purpose of that only.
Yes, sir.
A fundus examination, resident who is responsible for the examination, not ophthalmologist and putting drops. In a neurological fundus examination, ophthalmologist should never be called. Number 1. They should never administer any amount of patriotic to see the fundus.
Yes.
3. It should be done by the neurology resident if there are no neurosurgery resident, or a medical resident if there are no neurology residents, or an MBBS resident if no one is there. Fundus examination is an extension of clinical examination. And you should never call ophthalmologist to see the fundus. That is mandatory.
Yes.
Because ophthalmologist spoil the neurology. Sorry, ophthalmologist spoil the means they spoil the intricate clinical evaluating components of the examination by instilling the drops. That's
yes,
it.
sir.
You agree, sir?
Yes, sir. Very much true, sir.
Okay. ophthalmologist పిలవడం డ్రాప్ వేయడం ఐసీయూలో, తర్వాత నేనేమో హెరియేషన్ అనుకోవడం, ఆయనేమో కాదనడం అనే గొడవలు. Therefore, learn it, not call them for installation of drops. Consider that. That is not belittling, making you aware.
Diagnosis. Recurrent left parietal arachnoid cyst with raised ICP. Investigations. Hemoglobin 13 grams. WBC 10,200 cells per cubic mm. RFT within normal limits. Serum electrolytes normal. Viral
Why you made a diagnosis of arachnoid cyst when there is ICP? What is the clinical clue to make a diagnosis of arachnoid cyst in that case as a resident?
As there is...
It can be a tumor, recurrent. Why you made it arachnoid cyst?
Arachnoid cyst recurrence is more, sir. So previously...
It can be a recurrent tumor, cystic tumor. Cystic astrocytoma or a pillow astrocytoma or something else. What made you to say Only one point in history.
Projectile vomiting.
ఎన్నాళ్ళు వాడు బతికాడు 9 ఏళ్ళు బతికాడు మొదటి సర్జరీ నుండి. ఇది రికరెంట్ మ్యాలిగ్నెంట్ 9 ఏళ్ళు బతకడమ్మా అంతే కదండి. యూ షుడ్ మేక్ దట్ కామన్ సెన్స్ క్లూస్. Therefore, it is a benign recurrent disease, not a malignant recurrent disease. Simple. Am I right, sir? Malignant. But 9 years is an interval of more than 3-5 years. It can never be malignant. It is always a benign cyst. Then your diagnosis is done.
LFT normal, coagulation parameters are normal, CV normal, radiological workup.
This is a frontal chest radiograph PA view. Patient is in mild rotation. Cardiac shadow appears to be enlarged. Bilateral lung fields appear clear. Bilateral postophrenic angles are free and both tones of diaphragm are well outlined.
Yeah,
That makes an extraction.
You can see the cyst here, and this is the insular lobe here. The gray matter is seen here. This is the thalamus being shifted anteriorly. This is the caudate nucleus here. This is the globus pallidus and putamen here, and the internal capsule also is pushed. All these things are pushed towards that side. So the whole anatomy is pushed towards the opposite side. Yeah, they are not part of the mass. It's a foramen Monroe area which is getting compressed, and the third ventricles are not compressed. So the third ventricles, fourth ventricles are open. So this cyst causing agenesis of the parietal lobe. And the parietal lobe is not developed in this case, and the whole of the insular lobe is shifted anteriorly. Corresponding insular lobe is here.
Any relation to Cillian?
Not related to Cillian. Not related to Cillian. That's a very important point which you have mentioned, which is probably the reason why it is recurring again and again. So this is the opposite insular lobe here. So the insular lobe is almost pushed anteriorly. The basic angle has been pushed towards the forward anteriorly. It's an extra issue.
Diagnosis of intraaxial foreign coupling, which commonly occurs in the pediatric group with injury and then myelomalacia and then turning into a cyst. It is always post-traumatic axial injury, hypoxic or otherwise. Also, that is identical.
Is epidermolysis. Epidermolysis, sir. It doesn't show complete suppression on face. Here we can see complete suppression on face, sir. And epidermolysis shows diffusion restriction, sir. Arachnoidosis doesn't show diffusion restriction. Here in this case, diffusion restriction is not there.
Uniform, that is differential. You want to add anything?
Which part of the parietal lobe is agenous here? Can you tell by radiologically? Can you identify which gyri are not formed?
We have talked already Cillian, pre and post.
Maybe other cuts.
Got to show physiological diagnosis.
Any comments are mentioned?
No, sir. We actually, this kind of arachnoid cyst which leads to agenesis of the brain. So this gives us a lot of clue that about the neuroplasticity. So here almost the whole of the parietal lobe is absent. Most likely the sensory cortex is intact here. The superior parietal lobule, inferior parietal lobule, which includes the angular gyrus, supramarginal gyrus. So whole thing is not there in this case. Still, the patient may not have any. Of course, we didn't do a neuropsychological assessment because the patient is in an emergency situation. 71 years old. So these give us a clue about the neuroplasticity.
Neuroplasticity of the remaining slow and still everything is intact. Therefore, it is an ample time for the neurosurgeon to correct because there is a neuroplastic entire left. He can remove it and make whatever it improves. Because there is no focal neurological deficit in spite of massive occupation. Okay. It's almost 2/3 of the one hemisphere is occupied, 40% of it. And that is the beauty of 70-year-old man because it is an atrophic brain, has a lot of space to accommodate, and it is not real neuroplasticity but theoretical as well as objective neurological plasticity. You would have gone deficient component.
Diagnosis: recurrent left parietal arachnoidosis with obstructive hydrocephalus. Procedure: cystoventriculostomy, fenestration, and BP shunt. Position: supine position with head turned to right under general anesthesia.
Wonderful. There is one word which I don't know. Go back. What is fenestration?
Creating a opening, sir.
For what?
CS.
Because fenestration is a physiological word talked by the physiologists when they talk with you about glomerular structure. Right, sir? Glomerular basement membrane has fenestrations, that means holes. That's a physiological word. When you create it, it becomes a surgical word, fenestrations. Therefore, you are creating in the membrane multiple holes for what?
So, actually, sir, in this case, this being a recurrent case, surviving blank cystoventriculostomy wheels, this case they have done marsupialization. That was mentioned.
That means the remote of some.
Actually, the word marsupialization comes from kangaroo. Like a door and keep it open every time, which is not possible in this case. Why? That's the reason why the patient is coming again and again. It's not possible to do marsupialization in this case. And also, as you have mentioned, this is not connecting to any adjacent fissure.
That is cilium is more common, but it is not.
It's not connecting. So, if you just open it and close it again, it's going to accumulate. So, it needs to, in arachnoid cysts are very tricky to manage. This is a clear-cut example, although it looks easy to operate. But
therefore, fenestration is creating holes.
We need
Two way.
to establish.
Intro of findings. Previous incision was open, skin flap and muscle flap raised. Previous craniotomy flap raised. During durotomy, clear colored fluid drained from cyst. Ventricle wall was excised and sent for biopsy. Hemostasis achieved, wash was given, drain was placed. Incision was closed in layers and sterile dressing was placed. Surgical approach.
We wanted to, this is the opening area. I think, is this the navigation area? Yeah. This is the navigation one. Navigation guidance. We wanted to see, because the important structures are there, we wanted to see where we should make the fenestration or opening. So, next slide. So, we have opened the previous incision we had to open. Actually, there is no need to open so big area because we have a navigation. So, this is a navigator we have put here. See, we thought we would go from here. And this was the previous Omaya reservoir. So, we removed this also because it is already blocked. Next slide. The muzzle flaps are raised. Next slide. After the CSF came out, that means we are within the arachnoid cyst. Now, what we are seeing here is not the arachnoid cyst. This is the ventricle. This empty area is the arachnoid cyst. We are already in there. So, this is the brain, and in 3 dimension you can see this is the empty area. This is the ventricular wall which is projecting into the cyst. Next. Fully dilated because of the obstruction, and we have this is the opening we made into the lateral ventricle, tribone of the cyst. Not seen that much, we have opened, and we have to leave it. We can't stitch it there.
Post-operative course. Patient was extubated and shifted to ICU. Smooth post-operative recovery. Treatment given post-procedure. Patient was on NBM. IV fluids NS or oral 100 ml per hour was given. Injection monosep 2 grams 12th hourly. Amikacin 750 mg 24th hourly. Pantop 40 mg 24th hourly. Injection Levipil 500 mg 12th hourly. And injection PCM 1 gram 8th hourly was given. POD vitals are stable. Treatment given on POD7 is taxing 200 mg 12th hourly, Pantop 40 mg 24th hourly, Tab Levipil 500 mg 12th hourly. Histopathology.
Need of any scan again or no? Show the first of turn.
Sections examined from the cyst wall. These are the low power and high power images of this in a HMD stain section.
Here, the cystole lining shows fibrocollagenous tissue which are lined by single-layered meningothelial cells. These are the meningothelial cells lining the cystole. There is also adjacent glial tissue. So all these features are in favor of arachnoidosis.
He mentioned word single layer.
Single-layered. Flattened to cuboidal meningothelial cell line.
But in a double layer, there can be recurrence and secretory component. It is a single layer, there is no secretory component. Am I right, sir? And personal histology change. Not that you laid it, double layer with the next, how much is the volume reduction? Radiologist. Time decides.
Now that cystoventriculostomy is done, we need to establish free flow of CSF across the ventricle and
Both sides.
Both sides.
As
long as that is maintained, it will remain open.
Therefore, if you don't do ventricular cystostomy, then there are chances of recurrence because you cannot remove the entire layer.
100% it will recur. 100%. No doubt.
Here, the chances of recurrence is less because you given it two-way drainage.
Yes.
Any questions from other side? From neurology, madam. A wonderful case and the surgery is done third time in our institute, giving him. He is able to walk. And no neurological deficit.
What
That's
else?
most important.
But if 6 patient is fine and walking.
No headache and vomit. Thank you. Congratulations.
Conclusion. Arachnoid challenges.
Cardiology. We have a professor. I would like to introduce all the department of cardiology to you. Professor Vivekanand. Please come, sir. Dr. Bhargavi. Dr. Uma, Venkat Uma. Dr. Sridhar.
You are invited to come here, not to stay there.
Please come over, sir. So they have all joined our institute, and we have a full-fledged unit. Yesterday, Dr. Sampath has been relieved and he has gone back to Hyderabad. So I am sure the entire department of cardiology will be following what Dr. Sampath had done for all of us, and I am sure Dr. Vivekanand will be doing a wonderful job along with his entire team. I congratulate the entire team of cardiology. Thank you, sir. Thank you.
Vivekanand, good. Nice to see you. Not here for 5 minutes. Well, Sampath is relieved, not really that he will not come here. Okay? He has done 11.5 years, purely at the request of Pinnamaneni family. Because when we started that Pinnamaneni Polyclinic, the first cardiologist who was posted to the government hospital at that time. He has come because we had CCU open. He was seeing our patients in the evenings. That became a bond attachment like that. Then once we started 11.5 years ago, when the super specialty hospital is opened and cardiology is needed, I realized twisted his arm, bent his, and I requested. Now he has to come at least 3 days a week, and he has done a splendid job. And you know that already 10 people have, and he is also one of his disciples, students. There are about 30 students or there, 30 DM cardiologists through his hand where they have got trained. So, and he has done here the important difficult cases, referrals of 500 to 600, more than that, where they had all the patients were referred by cardiologists in Krishna district at Vijayawada, which is so he has done an excellent job. And I did mention to him and also told the secretary that we will be inviting him whenever we pull up the cases. Where is Vamsi? He's went. Okay. Wherever they pull up the cases, we talked about it yesterday. We told you also. When it is difficult, you think we need somebody, call him. Any number of times, he will come. So not that he is written off or he is not going to come here. He will come. Okay? That is the attachment of the family. And so is pledged to the Dr.pinnamaneni, who is he was not there when he joined, when he was there, because he passed away in 1980. So, but he is with us. He is seeing all the patients who are coming, and it is your responsibility now. Now your full department is here. Okay? So you take care of the patients as well as he has done all these 11.5 years with good spirits. And so I thank you. He said that I am getting him. You don't worry. He will. So he was telling me so many times, but I had very nice to see you, that you said you are going to take care of that. Okay? Please let us welcome all. God bless you. Thank you.
Announcement from the HOD of surgery.
Second Saturday of April, that is 11th of April, we'll be having a multidisciplinary CME which will involve Department of Medicine, Surgery, Anesthesia, Microbiology, Radiology, and the topic is septic shock. So all are invited to attend the CME. Time 9 to 4. It's a full day CME where morning we'll have 14 lectures, each of 15-minute durations. And in the afternoon, we'll have a panel discussion. There will be 4 cases of septic shock with different scenarios. And we'll have panels from medicine, surgery, critical care and anesthesia in the panel.
From Department of General Medicine, presented by Dr. Hamsini, Junior Resident Medicine. The session will be moderated by Dr. Surya Teja.
Good afternoon everyone. I am Hamsini, doing my third year post-graduation in Department of General Medicine. A 66-year-old man who is pastor by occupation brought to the hospital with chief complaints of fever and shortness of breath in 7 days. Patient was apparently normal 7 days prior. Developed acute onset high-grade intermittent fever with chills associated with grade 2 dyspnea, not associated with orthopnea, PND or chest pain. No complaints of cough or expectoration, no complaints of abdominal pain, vomitings or diarrhea, no urinary complaints. Past history, he is a known type 2 diabetes melter since 7 months on medication, tab metformin, 500 mg BD, not a known case of hypertension, hypothyroid, CID, severe epilepsy, bronchial asthma, no history of blood transfusions. Personal history, not a smoker, alcoholic, normal sleep and appetite, mixed diet, normal bowel and bladder movements, not a no known food allergies and drug and environmental allergies. Patient is conscious, coherent, well oriented to time, place and person, well built and nourished. Height is 177 centimeters, weight is 72 kg, BMI of 23 kg per meter square, GCS is 15/15, pallor, icterus, cyanosis, clubbing, lymphadenopathy absent. BP 120/80, pulse rate 110 beats per minute, respiratory rate 23 cycles per minute, temperature afebrile, saturation 96% on 4 liters of O2, GRBS 134. JVP 7 centimeters, no precardial bulge, apex bit left, 5th intercostal space, S1 is to heard, no murmurs. Per abdomen soft, on tender, no organomegaly, bowel sounds present. CNS, GCS was 15/15, bilateral pupils normal size and reactive to light, bilateral plantar flexors, respiratory system, trachea is in midline, shape of the chest is elliptical, symmetry of the chest equal in both sides, bilateral normal vesicular breath sounds, crepitations present, no V's. Provisional diagnosis, acute undifferentiated febrile illness with dyspnea, probable infections with bacteria or rickettsial with type 2 diabetes mellitus. This is a 12-lead ECG with showing sinus tachycardia. 2D echo, mild concentric LVH, no LVRWMA, no normal LVRRV function, normal LV filling pattern, mild MR, no AR or PR, IVC normal and collapsing, no pericardial effusion, clot or vegetations.
This is a frontal respiratory film. Patient is in rotation. Cardiac shadow appears to be enlarged. This could be due to mid-inspiratory film. there's mild prominence of bronchovascular markings noted in bilateral lung fields, and few fibrotic strands are noted in right lower and left upper zones. Right costophrenic angle and right dome of diaphragm are blunted. This could be due to possible pleural effusion with visual extension.
With neutropenia and lymphocytic predominant. RFT was within normal limits and electrolytes was also within normal limits. LFT is in normal limits. HbA1c shows 7.7. Leptospira, NS1-AG and malarial MPMF was negative. Treatment on day at the time of presentation. Fluids and ceftriaxone 1 gram IV BD, paracetamol S-verse 650 mg S-verse, tablet metformin 500 mg 12th hourly. Ultrasound shows splenomegaly with relatively well-defined hypoechoic area, suggestive of splenic abscess and splenic cyst. Bilateral enlarged kidneys with increased renal parenchymal echo pattern is correlated with RFT. Bilateral renal cortical cyst with grade 2 prostatomegaly. Postmortem residue shows 80 ml. Treatment on day is 1. Metrozil 500 mg IV TRD and injection ciprofloxacin 200 mg IV BD was added, and the rest was continued same treatment. General surgery opinion was taken in view of splenic abscess or splenic cyst. On examination there was no guarding, no rigidity. Features suggestive of free fluid or ruptured abscess are noted. CCT abdomen was advised. Treatment on day 2, we have continued the same treatment on day 2. CBP shows thrombocytopenia with neutropenia and lymphocytics predominant. And on day 2, thrombocytes platelets have improved. Blood culture shows negative. CRP 404 suggestive of inflammation. Procalcitonin was 4.84 suggestive of bacterial infection. 24 hours MPT shows 6.5 mg per day. Proteinuria. Dermatologist's opinion was taken in view of light color lesions over the bilateral legs observed over 10 days and mild itching on and off. Shows post-inflammatory hypopigmentation, idiopathic hypoverted hypomelanosis. CT chest.
Coronal and axial CT abdomen images, where we are able to see a well-defined hypodense lesion within the splenic parenchyma. In the given clinical context, this could represent splenic abscess.
Possible suggestive of infarct or infective etiology, suggestive of splenic abscess. Ophthalmology opinion was taken. Director fundus examination revealed bilateral eye moderate non-proliferative diabetic retinopathy. Review ultrasound was taken. Well-defined heterogeneous hypoechoic area measuring 3.7 into 2.7 centimeters with few areas of liquefaction, approx 20% noted in the splenic parenchyma. Another similar small hypoechoic area measuring 15 into 10 millimeters seen in the upper pole of the splenic parenchyma could be a small abscess. Treatment on day 3 and day 4, we have continued the same treatment but injectables are changes to the oral antibiotics. Day 4 and day 5 shows same neutropenia and lymphocytics is predominant. RFT was within normal limits. LFT shows hypoalbuminemia. I have continued same treatment on day 5. Splenic aspiration shows negative cultural sensitivity. KOH mom shows negative for fungal elements. No malignant cells. No organisms are seen in the gram stain. Smear shows lymphocytic with neutrophil against the proteinaceous background. Cell count 50 cells, neutrophils of 40% and lymphocytes of 60%. Gastroenterologist's opinion was taken, advised to do colonoscopy. Colonoscopy shows sessile polyp with internal hemorrhoids. We have continued the same treatment on day 6, 7 and 8 and 9. Post-aspiration ultrasound shows well-defined heterogeneous hypoechoic area of measuring 2.6 into 2 centimeters with few areas of liquefaction noted in the splenic parenchyma. Few hyperechoic foci are also noted within these possible any post-procedure. Final diagnosis, multiple splenic abscess secondary to salmonella, known case of type 2 DM with moderate non-proliferative diabetic retinopathy.
Infective endocarditis.
There is no vegetations.
And plain echo, can you find vegetations? Did you send blood culture for this patient?
Pardon, sir.
Blood cultures.
Blood cultures was negative, sir.
Infected
Inside there is an organ where
of splenic cyst. Splenic cysts are very common. 1% of the population can have a solitary splenic cyst. It might have infected and gone like this. Question? Wonderful question. Can you make a difference between a splenic infarct and a splenic abscess? Ultrasound wise or otherwise CSC?
It can be done on contrast enhanced CT, sir. Splenic infarct doesn't show any contrast enhancement.
Splenic infarcts are all subcapsular, venti-like but not venti-like in pulmonary infarct, but different. Whereas splenic abscess will have a differential density,
It will-
ultrasonal, not uniform.
And to reliably differentiate from cyst, the wall is irregular, sir. Cysts usually have
Therefore,
smooth
it is
wall.
not infected splenic cyst.
It is more likely
Irregular
abscess.
wall.
Yes, sir.
Therefore, on 3 counts, as per the radiologist, it is not an asymptomatic splenic cyst got infected, nor it is a splenic infarct because of the heterogeneity of ultrasonography as well as your CACT perfusion.
And even if we remove the clinical context and if we see multiple hypodense, lymphoma and such entities are ruled out because there is no lymphadenopathy and other things.
Lymphomas are the spleen and the last component.
Yes, sir.
And the moment you made out more than one abscess in the spleen, it is invariably to the drainage area of infected drainage area of the colonic component. Doctor, you must tell. Therefore, there are 2 abscesses, probably one resolved on its own with antibiotic, other resolved after aspiration. And the aspiration, you didn't tell the nature of the fluid. It is a thin fluid, thick fluid, or a turbid fluid, or hemorrhagic. Hemorrhagic or non-hemorrhagic?
Non-hemorrhagic.
I don't expect a splenic aspiration to be non-hemorrhagic. Very unusual. Because spleen is the highest intra-abdominal organ with highest amount of vascular supply. Because entire gut supply goes through the spleen back to the liver in the portal. That's why the infectious component in the colonic component. But colon is normal. Therefore, a 70-year-old, he had something else below the colon, that is an hemorrhoid. An infective ulcerated hemorrhoid, conceal it and make it in a 70-year-old man. Because he has an immune suppression, as evidenced by why he had a dyspnea. Then there is cardiac condition is normal.
The background of moderate anemia with high grade fever.
103 fever with chills make a 70-year-old man go for symptomatic decompensation.
Echo may not find vegetations always.
What we do not consider the component of bacterial endocarditis.
Because the fever with chills and with some lower limb like spots like thing, it could be.
Those spots are hypomelanotic geriatric spots. Ante kadama tella machchalu vayasuto vacheri 80 ఏళ్ళకి తెలుగులో. Am I right?
Because all vegetation may not be picked up on TTE. Because all vegetation may not be picked up. Because when we have seen one patient like that, sir.
How do you support and don't support the diagnosis of endocarditis with the splenic abscess?
Sir, usually when we do transthoracic echo, all the chambers will be better visualized in transthoracic.
There is no structural heart disease, first thing.
I'll come in stage. First we'll see the chambers. Chambers will be equally seen in both transthoracic as well as transesophageal. And mitral and tricuspid valves, we'll see any structural abnormalities. If we don't feel any mitral or tricuspid, usually we won't advise transesophageal. But if there is strong suspicion of endocarditis, then we'll do to see the appendages. So in transesophageal echo, we'll see right atrial appendage and left atrial appendage, where we can have clear view. Otherwise, for to see the chambers and valves, there is
And
no
the
clear
chambers
view.
are normal, it is not indicated to have it. Number 1. Number 2, what is the duration of fever?
7 days, sir.
That is also it.
3, no structural heart disease. Yes.
It can be possible, but with short history and no
Infarcts are
structural.
described classically once upon a time in pre-antibiotic era in White's textbook as splenic infarct, called otherwise known as there is some name. Kidney is called Dohely's lesions and spleen is called by other name of bacterial endocarditis infarcts. That is not infective emboli. But these 3 reasons I put it 7 days. Responded and cultures are negative on 4 grounds. The criteria for a bacterial endocarditis, 4 out of 6 are not fulfilled for the current. And we had some infected and healed hemorrhoid. An infected hemorrhoid may heal, but it is showered and the shower lands in the spleen, gradually comes up with after some time. Therefore, when there is no lesion, including hemorrhoids, then it is suspicious. You have to go for that. But something is there, it is a consequence of that. He responded to it. It can be a, but diarrheal illness is absent. Therefore, it is because salmonella diarrheal infections, non-typhoidal, can produce bacteria which lands in spleen and produces. The other component of splenic abscesses with prolonged fever of late is melioidosis. Melioidosis, that is Pasteurella group of bacteria, but not in this case because it's a. Anything you want to comment further? We responded to chloroquinolines as well as not primaries. And post. What organ in inside of the body will never have abscess? I don't know. No, the tongue abscess will be seen by neurologist all after the epilepsy and the bite. Because I have seen tongue abscess post-epileptic. Oh, primary. Primary.
No, the reason I remember that is
highly vascular.
When we do our thesis, there is cases, one of the things, or interesting cases.
When Dr. Sudha was doing her MS, so she had one case with tongue abscess, where we have proved that it's abscess and it's shown. It's rare, we haven't seen. That's why I wanted, curious to know, if so many people, surgeons are around, how many of you have seen? But you know, Vamsi very intelligently said, nails and hair.
Nails can get abscess. The classical non-infect abscess subungular is your osseous component. Hair is not a lifeful organ except the root. Next slide, please. Wonderful. Any questions? You want to make any comments? Splenic abscess also can occur. Rarely, everything is normal. Go for radiation therapy or live with radiation. They will have immune suppression and splenic abscess. Because everyone, when he takes a meal or when he purges, he will have a bacteria which is contained by the spleen as well as the liver. When there is immunosuppression, these two cannot contain. In alcoholic, it produces liver abscess maybe. In non-alcoholic, it can produce a splenic. But they all regress because spleen is the highest chief marshal of immunology, which will not allow anything to go.
From Department of Pediatrics, presented by Dr. Gnapika, Junior Resident, Department of Pediatrics, Moderator, Dr. Sandhya Dasari.
Good afternoon everyone, I am Dr. Gnapika, second year postgraduate resident, Department of Pediatrics. Today I am presenting a case of silent pressure surge and moderator for this session is Dr. Sandhya Dasari, Professor, Department of Pediatrics. This is a case of U1, 7-year, 8 months boy child hailing from Gannavaram, presented to ER with complaint of staring episodes followed by stiffening of both upper and lower limbs lasting for about 10 minutes. History of present illness. Child was apparently normal till 7 days back. Later he developed facial puffiness which was insidious in onset, initially noted around eyes and later progressed all over to the face. And complaint of sore throat since 5 days which is acute in onset, associated with difficulty in swallowing, not associated with fever, cold, cough, change in voice and ear pain. Child was taken to a local hospital, treated as throat infection with intravenous antibiotics for 4 days as per mother's history and discharged on oral medications. On 1 day prior to admission, complaint of episode of vomiting which was moderate in quantity, food and mucus as content which is non-bilious, non-projectile and not blood tinged. Complaint of headache which was sudden in onset over occipital region, non-radiating, not associated with blurring of vision, photophobia and there were no aggravating and relieving factors. And complaint of decreased urine output since 1 day which is decreased in frequency, pale yellow in color, not associated with burning micturition, hematuria and urgency. On the day before admission, in the morning around 8 a.m., when child was having breakfast, developed sudden onset of staring episode followed by generalized stiffening of limbs lasting for about 10 minutes associated with drooling of saliva followed by drowsiness. And there was no involuntary passage of urine or stools, tongue bite, frothing, deviation of mouth and fever. After 1 hour, aborting the episode in ER with anti-epileptic medication, child started responding to commands, communicating with parents and activity improved. Later the same day, after 9 hours of admission, around 6:40 p.m. in the evening, child developed a similar episode of staring and was unresponsive to pain stimulus or verbal commands for about 10 minutes, where again an anti-epileptic medication was administered and event was aborted. And there was no history of preceding trauma or fall, no history of neck stiffness, no history of diarrhea, no history of sweating, irritability, cola-colored urine, no history of cough, fast breathing, palpitations and syncope. Past history. History of upper respiratory tract infection 3 weeks back prior to current illness and treatment was taken from an RMP. And history of fall while playing 3 weeks back with healed abrasion and formed scab of 3 into 3 centimeters over lateral aspect of both knees. Family history second by birth order, born through a non-consanguineous marriage and no history of seizures in the family members. Antenatal and natal history was eventful, immunized as per national immunization schedule, and there were attained development milestones as per age. Nutrition history taken by 24 recall method and there was no deficit observed in protein and calories. Socio-economic history according to modified Kuppuswamy classification belongs to lower middle class, that is class 3. General physical examination. At the time of admission, child was drowsy with GCS 13/15, well nourished, and there was no pallor, icterus, cyanosis, clubbing, lymphadenopathy and pedal edema. Healing scars were present over both knees. And child had right hand post polydactyly with syndactyly and left hand post polydactyly, and there were no signs of dehydration. Skull and spine were normal, no neurocutaneous markers according to SMR staging pre-pubertal. Vitals at emergency room, temperature was 98.5 Fahrenheit, pulse 88 beats per minute which was regular, normal in rhythm, no radio-radial or radio-femoral delay with normal volume. Respiratory rate was 21 cycles per minute, thoraco-abdominal type, saturation 99% and CRT was less than 3 seconds. BP readings were taken over all the 4 lower limbs in supine position where BP readings were maintaining according to American Academy of Pediatrics 90th percentile. Anthropometry, weight was 75 to 90th percentile, height 90 to 97 and BMI 75 to 90th percentile. Systemic examination. Child is examined in supine position after regaining consciousness. Central nervous system, higher mental functions, child is conscious, oriented to time, place and person. GCS was 15/15 with cooperative behavior and fluent speech. Cranial nerve examination, all cranial nerves were intact. Motor system, normal. Reflexes, both superficial and deep tendon reflexes were normal. Cerebellar signs, upper and lower limb, no abnormality was seen. Sensory system, all sensations were intact with no signs of meningeal irritation. Skull and spine were normal with regular and bowel and bladder habits. Other systems, no abnormality was detected. Provisional diagnosis, query hypertensive encephalopathy secondary to post-infectious glomerulonephritis or intracranial bleed or intracranial space occupying lesions. Course in the hospital. On day 1, child was kept on nilper oral with oxygen support through a polymask 5 liter oxygen, IV fluids, DNS and KCL with 2/3 of the maintenance, injections ceftriaxone 100 mg per kg per day 12th hourly, pantoprazole 1 mg per kg per day 24th hourly, and levetiracetam loading dose 40 mg per kg per dose stat followed by maintenance 20 mg per kg per dose Q12th hourly. Ophthalmology opinion was taken where no signs of intracranial pressure features and fundus examination was normal initially, and neurology opinion was taken and advised to continue the same treatment and review after neuroimaging. On day 1, where child had a similar episode, it was aborted and child was unresponsive to pain, stimulus or verbal commands, where pupils were examined which was normal in size and reactive to light. Vitals at that time was heart rate 146 per minute, respiratory rate 32 cycles per minute, temperature 98 Fahrenheit, saturation 99% on 5 liter oxygen, BP was 150/90 mmHg, measured in right upper limb in supine position, which was more than 95 plus 12 mm Hg percentile, and GRPS 102 mg per deciliter. Where episode was aborted with levetiracetam 20 mg per kg per dose, and in view of persistently elevated BP levels and seizure episodes, IV levetiracetam stat dose was given, CT scan, ECG and 2D echo was planned. Investigations done on day 1, hemoglobin was 9.3 gram percentage with total counts 17,470 with neutrophilic predominance and lymphopenia. Other parameters were normal in complete blood picture, and CRP was 6.22. Serum electrolytes along with calcium and magnesium were within the normal limits. RFT and LFT were normal. In CU, blood was 2+. In microscopic examination, RBC was 6. CT brain.
Axial and sagittal CT brain images.
Will you further comment before the CT, very important microscopic examination as a resident? Comments on that? You had a blood 2+ and RBC. Are related or unrelated as far as interpretative value is concerned?
They are related, so suspect.
Then what is the interpretative value of RBC unless you coin and make a morphometry? And what is the inference of blood? Is it a free blood? If so, what is the inferential value at this point of time? When you said that there is no Coca-Cola urine.
If not dark color or cola colored urine, we can, in case of PIGN, we can suspect a microscopic
PEC per hyperfield is abnormal, more than 2, particularly anti. And therefore, you must talk about the morphology of the RBC. And the blood, RBC present will give a positive blood. I don't know. Pathology, resident or otherwise, make some comments.
Yeah, the one blood which is it is a chemical reaction. So even if RBCs are there also, you will get blood positive. Even in hemolysis also, you will get it as blood positive. But it has to correlate with the microscopy. If microscopy is showing only 6 and blood is showing 2+, that means definitely there is little bit of hemolysis is existing. Because 6 will go with 1+ is okay. 2+ means there is something.
Therefore, you want to look into the morphology of RBC.
Yeah, there is free hemoglobin is also present.
Therefore, there is evidence of free hemoglobin. There is evidence of hematuria, and you have to comment on the RBC to know dysmorphic or morphic, normomorphic. If you have seen that and gone to the lab, then you would have got the idea whether it is dysmorphic RBC and your diagnosis is over. And when it is a normomorphic RBC, then the Pandora's box is bigger. Definition of hematuria is more than 2 RBC, sufficient to call it. International. Done.
CT brain.
Axial CT brain images, brain window and bone window, where we are able to see a partial empty cella. And on bone window, we are able to see bilateral optic nerves appear prominent, which are signs of rise intracranial pressure. Rest of the brain parenchyma appears normal.
Conclusion. I don't want to
there are some signs of rise intracranial pressure, sir. Apart from that, brain parenchyma is normal. No positive findings are there.
Rise intracranial pressure with effacement or barrier lost. It is only plain.
Yes, sir.
Am I right?
Yes, sir.
No. We'll come to it later.
2D echo and ECG were done, which was normal. On day 2, vitals all were normal except BP 140 by 100 mm Hg over right upper limb in supine position, which was 95 plus 12 percentile. In view of persistent elevated BP levels, tablet nifedipine 10 mg stat dose was given and continued the same treatment. Investigations were done on repeated CUE where blood was 1+ and RBC was 5. TSH within the normal limit, C3 complement levels were 32 which were low and C4 16, ASO titers were negative. Chest X-ray.
PA view, trachea is in midline, cardiac shadow appears to be within normal limits, bilateral lung fields are clear, bilateral costophrenic angles are free and both tones of diaphragm are well outlined.
The because I expect something to be there in the 2D echo. Any comments? Apparently everything is normal. And they have not noted any volume expansion status, volume overload. As a resident of cardiology, there is one I will ask that question. The echo will reveal any amount of volume overload, if so, where? You can answer because cardiology resident is absent. You had a hypertension of 150 by 100 or something, a child, this is very abnormal. And he had some amount of urinary decrease output. He had an hematuria and blood. Therefore, you have done echo for what purpose? To volume overload or purpose of detect cardiac lesion. You are right, because you had a syndactally post, can have a cardiac abnormality. Therefore, you are right to order for echo to exclude a cardiac lesion. But there is not. But if it is volume overload, what do you expect? I don't expect an IVC to be normal, nor the other. RESP is normal 25 for a child of 7 years. I don't know. Comments?
Fairly normal, sir.
Why? That is an incongruous finding with reference to a lateral diagnosis.
University abdomen and pelvis was done, suggestive of thickened and edematous gallbladder wall, minimal ascites and mild right pleural effusion. Nephrology opinion was taken and advised to control BP readings to 50th percentile and to add amlodipine and beta blockers. And on day 3, all the vitals were normal except BP maintaining 95 plus 12 and IV Levitral stat dose 0.7 mg per kg per dose was given along with oral amlodipine 2.5 mg per dose 12 Tadli was added. And on day 4 and day 5, in view of persistently elevated BP levels, antihypertensives were added. Oral enalapril 0.08 mg per kg per day OD, Levitral 1 mg per kg per dose OD and continued oral amlodipine. And in day 5, increased enalapril to 5 mg per day BD.
As a resident, I would have asked you to go and take the urine for microscopic examination, not examination biochemical way of blood and RBC, but microscopically to know whether there is an RBC cast to clinch the diagnosis, nothing else in this case. Do you agree, madam? RBC cast?
Yes, sir.
But not
RBC cast, because that will tell the whether it is glomerular in origin or it is extraglomerular or something else.
No. When you have hypertension, the first duty of a resident, when there is hematuria is glomerular origin or non-glomerular origin, can be seen by the resident by sponge or other sample and see under microscopic events like not oil emission. Am I right, sir? That will cleanse the diagnosis.
How about C3 levels, sir? C3 levels are also low, and considering the clinical history, can we consider? Here persistently C3 levels are low with the clinical history and the blood pressures are high, hypertensive encephalopathy. So we are mostly, and with the history of respiratory tract infection as well as skin abrasion. So clinically we are correlating. I do agree, sir, that she should have gone and seen under the microscope for the crenated as well as the dysmorphic RBCs. Yes.
It need not be 1,000, it need not be 100 or 10.
Cast, as the name indicates, it is the shape. The shape, when you are having the shape and you are having RBCs on it, definitely it becomes an RBC cast.
Crenated RBC is hallmark of glomerulitis. 2 crenated RBC adjacent and beyond is sufficient to call it as RBC cast. 3 is you are very lucky. But not 10 and 20. Then it is something else, not primary glomerular bleed. Over. Why I am interested in that? As a pediatric house surgeon, we used to see hypertension encephalopathy means immediately urine examination and confirmed diagnosis of AGN, acute glomerulonephritis, or nephritic natter. We will talk a little. This Madam will talk.
On day 3, spread which was within the normal limits and urine culture was negative. And the next 3 consecutive days, day 6, 7 and 8, BP was maintaining with 90th percentile and same treatment was continued. And on day 6, CUA was repeated and blood was 2+ and RBC 7. Urine protein and culture throat swab was negative. Ophthalmology opinion was taken on day 6 where mild hyperemia of both eyes, AV crossing present in both eyes, suggestive of grade 1 hypertensive retinopathy changes. And in day 8, C3 was repeated and it was 34.2, which was low. RFT and serum electrolytes were normal. MRI brain.
These are axial flare images where we are able to see curvilinear flare hyperintensities involving left parietal and occipital lobe. And these features could represent posterior reversible encephalopathy syndromes.
On day 10 to...
Posterior and addition of a normal thing not detected once upon a time because of our extravagant MRI investigation, nothing else. The press is pressed into the 21st century because the press to be detected is not MRI there in 20th century, but it is not new. It only tells here vascular integrity of the cerebral structures is lost, whatever the reason. It can be migraines, it can be toxemia, it can be encephalopathy, or it can be hypertension.
Less actually. Maybe because the workup maybe have not done, possibility. We were looking at the meta-analysis because we wanted to know the percentage of pediatric breast because it's a small immature brain. And obviously the rare part of the brain is going to get affected.
In a new dimension.
Yes, sir. We have done MRI to look for breast. That is, of course, all end organs we have screened because we wanted to give a child with functional capacity. Because of such high blood pressures, there is a very high tendency to either lose the eye or a limb or a speech or possibilities are there. So, judiciously, this blood pressure had to be controlled using 3 antihypertensives along with the, we were discussing with the nephrology team and Dr. Varun was guiding us how to, because blood pressure management in a pediatric case with 3 antihypertensives is a little tedious, and we have usually by 1 antihypertensive it used to get controlled previously, but in this case the intensity was more and obviously MRI is also showing breast changes.
Day 10 to day 12, BPs were maintaining with 50th to 90th percentile and same treatment was continued. In view of poly and syndactyly of bilateral low upper limbs, plastic surgery opinion was taken and advised syndactyly release with excision of bone and excision of accessory fingers on ulnar side. Diagnosis: secondary hypertension due to PIGN complicated by posterior reversible encephalopathy syndrome. On follow-up, effective blood pressure control was achieved with normalization to less than or equal to 50th percentile within 3 weeks, enabling stepwise tapering and eventual discontinuation of antihypertensives. Fundus findings were normalized with control of blood pressure. C3 levels normalized on follow-up at 3 weeks. Child continues to maintain normotension on regular follow-up.
Wonderful case, but
and fundus is normal, sir, on follow-up.
Great old case of last 30 years, now again see and presentation. Wonderful. You have done C3 and it is low. What is your inference of that C3 in this case? Complement 3. It tells what to you as a resident? Edgar. It tells you as a primary immunological reaction, it tells you an aberrant immunological reaction, it tells you a normal immunological reaction. C3 in this case. That's a question. He has given an answer for you, but you didn't catch it. You have done it. It is recorded again. It is likely to be primary autoimmune of SLE group. And 2, it is low in a primary infection unless complicated by autoimmune component. It can have a C3 will be low. That is a post-streptococcal, post-infectious glomerulonephritis. Comes down and goes up, but not in
3 weeks it has
primary
normalized.
autoimmune diseases. That is SLE group of things. That you should know.
Thank you.
Next, any questions?
General Medicine presented by Dr. Hema, Junior Resident, Moderator Dr. Surya Tejas.
Afternoon, everyone. I'm Dr. Pinnamaneni, second year postgraduate from the Department of General Medicine. Today I'm here to present an interesting case presentation. And the title was A Tropical Anguma, Unraveling Chronic Relapsing Abdominal Pain with Transient Intussusception. My moderator was Dr. Surya Sir, Assistant Professor from the Department of General Medicine. A 16-year-old male from Srikakulam presented with recurrent abdominal pain and weight loss for the past 3 months. History of presenting illness: patient was apparently in his usual state of health 3 months back. Then presenting complaints started as abdominal pain in the left lower quadrant since 3 months, which is intermittent and cramping type of pain. Subacute onset, which is aggravated after 2 to 3 hours of food intake. Relieves spontaneously, which is associated with nausea. Patient has a history of weight loss, 4 kg in 3 months, which is significant weight loss. Recurrent episodic abdominal pain over 3 months, each episode lasting for a few hours, 2 to 3 hours after the food intake, which is self-resolving. Patient has no history of fever, night sweats, chronic loose stools, black colored stools, bleeding per rectum, persistent vomiting or abdominal distension, no history of chronic cough, TB contact, perianal disease, lower limb swelling, hydrocele, blood in the urine or white colored urine, no addictions. Past medical history: patient has similar episodes 2 times prior to this. He has been treated conservatively. No definitive diagnosis was established. CBP, which was done outside during the first episode, was within normal limits, and creatinine was also within normal limits. Ultrasound abdomen was done during the first episode, which has been given as the right iliac fossa and retroperitoneum. Multiple mesenteric lymph nodes with loss of hilum seen in the periumbilical region and right iliac fossa. Maximum short axis diameter measuring 6.3 mm. Almost 3 areas of the bowel within the bowel appearance. Target sign is seen. So in the left iliac fossa, over segments of approximately 3 cm into 1.3 cm, and 1 in the periumbilical region towards the right side of midline over a segment of 1.3 cm. Mild periregional edema seen surrounding the ones in the left iliac fossa. Diffuse bowel gas shadows seen throughout the abdomen. Few dilated fluid-filled small bowel loops seen with to and fro peristalsis. Small amount of free fluid seen in the pelvis. Impression is given as likely small bowel intussusception. 3 sites are visualized in the left iliac fossa and periumbilical region towards the right side of the midline with proximal small bowel dilatation. Mild mesenteric lymphadenopathy and minimal ascites. X-ray at abdomen was done outside.
This is a frontal abdominal X-ray showing small bowel loops are dilated with multiple air fluid levels suggestive of small bowel obstruction.
The visualized small bowel loops show gaseous distension with multiple greater than 5 air fluid levels suggestive of small bowel obstruction. This was a treatment advised in outside hospital. IV fluids to unit sinus 120 ms. Injection piperacillin tazobactam 4.5 grams IV 12 hourly. Injection metronidazole 100 mg IV 8 hourly. Injection butyl scopolamine ammonium bromide IV 12 hourly. Injection pantoprazole 40 mg IV OD. And CECD abdomen was advised along with the gastroenterologist opinion. CECD abdomen and pelvis was done on the day 2. Bowel loops showed short segment jejunal intussusception measuring 39 into 36 into 32 mm seen in the left pelvic cavity. Mild thickening of the bowel wall seen involving bowel segment and proximal jejunum for a length of 8 to 10 cm from involved segment. The intussusception is spontaneously resolved on giving oral contrast and could not be seen in the arterial and venous phase images. The thickened jejunal segment in the left lumbar and left iliac fossa regions showing mild arterial enhancement with no significant adjacent mesenteric fat inflammation. Multiple enlarged lymph nodes seen in the mesentery. Large one measuring 14 into 8 mm in the right iliac fossa mesentery. Minimal interbowel loop free fluid in the peritoneal cavity and pelvis. Impression was given as short segment thickening of jejunal loops in the left lumbar and left iliac fossa regions with no significant mesenteric fat inflammation and with no significant upstream dilatation of the bowel. Likely radiological possibilities could be infective cause and inflammatory etiology like Crohn's disease. Short segment transient spontaneously resolving jejunal intussusception in the left pelvic cavity. Patient has visited gastroenterologist on day 5 of symptoms. Advised for apogee endoscopy and colonoscopy, and advised TAP cefuroxime peroxidil 325 mg per oral BD, TAP metronidazole 400 mg per oral TID, TAP mepivarin hydrochloride plus fluorodiazepoxide per oral BD. upper GI endoscopy and colonoscopy were done, which were in the normal limits. Normal mucosa. Patient revisited gastroenterologist after 10 days with the duodenal biopsy, fecal calprotectin, LDH, and serum transglutaminase antibody. CBP on day 10 is showing with eosinophilia with 13% of eosinophils. The fecal calprotectin was within normal limits, which is 16.4 micrograms per gram, which is negative if it is less than 50. Serum LDH is 163, which is within the normal limits. Serum transglutaminase antibodies were also within the normal limits. Duodenal biopsy was done, taken from the D2 segment of the duodenum, which is a suggestive duodenal mucosa with unremarkable histomorphology. Advised TAP as omeprazole 40 mg paroral OD, TAP meldonium hydrochloride plus chloride isoxide paroral BD, TAP triodol plus paracetamol paroral BD, TAP lactobacillus paroral OD. Revisited gastroenterologist on day 21 with the complaint of abdominal pain since 2 days. Advised for endoscopy. Patient has undergone ultrasound abdomen pelvis on day 21, which showed few enlarged lymph nodes in mesentery. That is measuring 19 into 8 mm in the left lumbar mesentery. Minimal interbowel loop fluid in the peritoneal cavity and pelvis, no evidence of intussusception in the present scan. He has undergone CBP, which is showing eosinophils, which is 14%, and creatinine CRP was within the normal limits. Personal history: patient consumes mixed diet, all and black habits are regular, sleep and appetite is normal. He has a history of pets at home, which is a dog, no addictions. Family history is nil significant. General examination: patient is conscious, coherent, oriented to time, place, and person. He is thin built and nourished. Height was 164 centimeters, weight is 50 kg. BMI was 18.6 kg per meter square. There is no pallor, no icterus, no cyanosis, no clubbing, no lymphadenopathy, and no edema. Vitals at the time of presentation was BP was 90 by 70 mm Hg, measured in the right upper limb in supine position. Pulse rate was 86 beats per minute, which is regular. Normal volume and character with no radioradial or radiofemoral delay. Respiratory rate was 18 cycles per minute. Abdominothoracic type. Saturation was 99% at the rate of movement. Temperature was 98.4 degrees Fahrenheit. Systemic examination: CVS was within the normal limits. Respiratory system examination was within the normal limits. Per abdomen, there is tenderness was present in the periumbilical and left iliac fossa region with no organomegalism. CNS was within the normal limits. Provisional diagnosis: chronic relapsing abdominal pain, query abdominal tuberculosis. Treatment at the time of admission: we have given TAP albendazole 400 mg paroral OD, TAP doxycycline 100 mg paroral BD, TAP omeprazole paroral OD, TAP multivitamin paroral OD. ECG at the time of admission: this is a pulsed standardized ECG which is showing normal sinus rhythm. Chest X-ray.
PA view. So, patient is in mild rotation. Cardiac shadow appears to be within normal limits. There's hyperinflation of bilateral lung fields with mild flattening of both lobes of diaphragm. Bilateral costophrenic appear free.
At the time of admission, which is showing 13% of eosinophils with a ESR of 5 mm per hour. RFT was within the normal limits and serum electrolytes were within the normal limits. LFT and CUV were within the normal limits. CCD abdomen and pelvis was done.
These are the contrast enhanced images where we are able to see multiple enlarged mesenteric lymph nodes. Apart from that, no significant abnormalities detected in the organs and outputs.
Specific mesenteric lymphadenitis with splenomegaly of 12 centimeters. CBP was repeated on day 2 of admission, which is showing eosinophilia of 15%. Absolute eosinophilic count was sent, which is 1080 cells per microliter. Normal range was 0 to 500. Final diagnosis we have made was non-specific mesenteric lymphadenitis, which can be atypical filariasis. We have sent filarial antigen, circulating filarial antigen, which came out to be positive. Treatment at the time of discharge: antifilarial therapy. We have given diethyl carbamazepine 6 mg per kg per day for 12.
Till we have seen the reports of the peripheral until we have seen the report of complete blood picture, we have still having this dominant tuberculosis in our mind, because on CBP the ESR is only 5 mm. And also, patient is having these complaints for the past 3 months.
3 months recurrent episodes. In between is absolutely normal going to school. That cannot happen in a primary tubercular abdomen. And once the pain starts, either it should be relieved completely or it should have a progressivity of obstruction, not relieved, or otherwise. Therefore, total relief of the complaints and going back to his normal activities is a relapsing acute pain abdomen in an adolescent. Only two things. One is a mesenteric meningitis. If there is vomiting but no headache, abdominal migraine. The third one is a non-specific mesenteric meningitis reaction to any of these extraneous antigens, including worms, insects, and many things, which can propel and give rise to a reversible intercession. In this case, when there is a normalcy of the pain abdomen and a febrile, I don't expect him to go and diagnosis of pain. But I think in India, primary, that's something. But not intersection resulting in tuberculosis resulting in it can never go on its own without the surgical intervention. Whereas non-tubercular intersection can be due to many reasons which will on their own in the past mortem or do some investigation they relieve in pediatric case group which they see many number of times without congenital lesions because it is already there. Therefore, that response to doxycycline and dimethyl carbamazepine, he was happy for how long? Gone back, discharged?
He was discharged with this medication, sir, but after 2 months, he again had.
How many months?
2 months.
He continued the treatment?
No, sir.
That is it. Therefore, departed, not continued, recurrent. Then what happened in the recurrence? You know, make it. Wonderful. Leukemia audio is good. He has done many number of times CBP. CBP.
Why not lymphomas?
There is no mass lesion anywhere. Not generalized lymphadenopathy.
Because the lymph nodes are there. There are other differentials for that mesenteric lymphadenopathy.
Wonderful. Apart
from
your question of mesenteric lymphadenopathy as a compartment of lymphoma is very unusual in child group, but it is moderate adult, which is a mantle cell lymphoma.
This patient has a significant weight loss, sir.
In both lymphomas, spleen should be present.
Here there is splenomegaly is written on the.
But the lymph nodes are significant diffuse, small. Number one. Is CBP recurrently absolutely normal without any inflammatory component? 3 SR తక్కువ ఇంట్లో ఈజినోఫిలియా ఉందన్నట్టు ఈజినోఫిలియాలో ESR ఇప్పుడు తక్కువ హైపర్ ఈజినోఫిలియా. Next, what happened?
He has followed. He has a history of similar episodes 60 days, that is 2 months after the discharge, and has undergone diagnostic laparoscopy. Diagnostic laparoscopy was outside after 2 months after the discharge. Liver appears to be normal in size, smooth surface. Gallbladder appears to be normal, no distension or inflammation. Pancreas appears bulky. Stomach and duodenum appears to be normal. Small intestine appears to be normal from region flexure to ileocecal junction. Appendix normal in position and appearance. Cecum and colon appears to be normal. Omentum appears to be normal. Lymphadenopathy noted along the major vessels. Peritoneum, no free fluid adhesions, deposits or tubercles. Urinary bladder was normal. Rectovaginal pouch was clear. Histopathological, there was a mesenteric lymph node biopsy has been taken, and this was a histopathological report. Macroscopic examination showing they have received a single soft grey white tissue bit measuring 0.5 centimeters. Entire tissue was processed in a single block. Macroscopic examination section from the specimen showed structure of the lymph node with well-defined capsule and subcapsular sinus. Cortex showed plenty of the active follicles. Sinusoids are dilated and filled with histiocytes. No granulomas noted, no parasites were identified. There is no evidence of any malignancy in the sample submitted. Impression was mesenteric lymph node biopsy, which is due to the active hyperplasia.
Comments, compliments, and criticism. A3Cs.
The only thing which has provoked us to go with the diagnosis of or to think about filariasis is the patient having a penta lymphomas.
Not only penta, one parasitic antigen is positive.
Yes.
2 is hypereosinophilia. 3 is relapsing, non-symptomatic but not organic, except one episode of indecision. 4, he responded but he did not continue. A dog can cause varieties of antigens which can cause reactive dysenteric lymphadenitis. In our good olden days, dysenteric lymphadenitis, you give that and make him to sleep well and everything subsides. But it has gone to an enormous amount of stupendous, within brackets I don't pronounce, invasive investigations, including laboratory. If it had continued about 3 weeks and then stopped in another 1 month and second course, everything should have been subsided. But fortunately, the drama has been well documented, meticulously. To show all the scenarios acted need not be Shakespearean, but they are shaking the spear, but there is nothing to shake inside. Thank you. We therefore call him and get him the 3 weeks of diagonal carbon repeated at the interval of 1 month back. NET, I congratulate all the presentators of the cases of varied nature, Department of Neurosurgery, and the Department of Pediatrics, Department of Medicine, and again Department of Gastroenterology and Medicine. All 4 are very brilliant cases, really useful. From a simplistic viewpoint with a horrendous investigation, and a complex viewpoint with a brilliant amount of therapeutic outcomes in all the cases.